Hello. Can everyone hear me? Hi, thank you for coming. My name is Malika Savarwal. I'm the president for Students for National Health Program. Today is Halloween, but it is also Students for National Health Program's National Day of Action, Treat Not Trick. As medical students and healthcare professionals, we believe private health insurance is a trick and we only want to treat our patients. So today we're having this community speak out featuring a few physicians and students who support single payer healthcare, and they're just going to speak about their personal experiences, either as children accessing the healthcare system or as adults, and physicians who see patients suffer in their practice. So thank you everyone for coming and listening to us about that. We're also collecting signatures of support for Representative Yarmouth. He already supports HR 676, and we just wanted to let him know he has students and other community members who also support it, and to invite him to come out and do a community forum or a discussion on single payer healthcare. So hopefully we can get that happen this year. So without further ado, we're going to start with Dr. Christian Furman, and we'll just pass the mic on from there. Thank you.
Yes. Well, thank you for inviting me, and happy Halloween, everybody. I just want to talk about my experience. I went to medical school here and did my residency here and worked at the VA when I first got out of practice. And the VA is really a single payer health system, and that system really works. And I just want to kind of explain why I think it works and why we should all go to that system. One thing is they had the electronic health record first, and it's an integrated system. And now what's so hard with all these different payers is there's all these different electronic health records, and we have no idea what's really going on with our patients. So the VA was able to do that very, very well. I'm also in geriatrics and palliative medicine, and we really work with interdisciplinary teams. And having a single payer system, you can support interdisciplinary teams because it's a health system. And so the inpatient, the outpatient all works together. In geriatrics and palliative care, we do a lot of home visits. It's really hard for a health system to support home visits unless you have that one payer source that gets the benefit of the decreased hospitalizations and the outpatient care and the home visit care. So the VA figured that out a long time ago, and they've been able to be progressive and the leaders in geriatrics and palliative care because it's a single payer health system. Also, there's a lot of decreased administrative costs and the decrease in the complexity of a single payer system. And that's one of the big examples is the electronic health record. If you just had one health system, you wouldn't have to have all these health systems competing for their electronic medical record. And we talk about Medicare for all. You know, I'm a geriatrician, so pretty much all of our patients are Medicare patients. And we see it working in those patients. They actually get good health care. They are able to stay out of the hospital. We have a system approach. We have pharmacists. We have social workers helping us. So when you have a health system, you can look at that interdisciplinary team and get great care for everybody. And also, I think a lot of times people worry about having to, having a single payer system, you're going to have a two-tiered approach to healthcare. But really, now we already have a two-tiered approach to healthcare. So it can't, it's not going to be any different from what we have now. It's going to be able to get more people, more coverage. And that's what's so great in geriatrics. Like all of our patients have health insurance. They're all covered. They all can get their medicines. They can see a doctor, and they stay healthy because of that. Okay, so I think the next person is Dr. Barbara Casper.
Thank you for allowing me to speak today. I really appreciate this opportunity. I've had the fortune of caring for underinsured and uninsured patients for 30 years, and so I have seen both sides of the lack of insurance. So prior to the implementation of the ACA, many of my patients were uninsured and therefore could not get the care that they needed. Subsequent to the implementation of the ACA, I've seen a dramatic change in that from the standpoint of our patients now are able to get their medicines, are able to access physicians. There was an article published in JAMA Internal Medicine that actually compared our system to that in Arkansas, who implemented a different way, but they expanded Medicare, and then Texas. And what they saw was a dramatic decrease in the number of ER visits, an increase in the number of primary care visits, and an increase in the number of people who actually took their medicines. So that's a good thing. The downside of that is that that is not a consistent approach for every state. And I can tell you that I have patients that actually live in other states that keep their primary residence here so that they can have health insurance because the state they live in does not have health insurance. In addition, as you know, in Kentucky, we're facing a threat to the expansion of the ACA with the changes that our governor has recommended, which will really mean that many of our patients will not have insurance anymore. So we will go back to the way things were prior to that. The last thing I'd like to say is from a physician standpoint, this system is very difficult to negotiate. Because of the way that the ACA was implemented, there are many different insurance companies involved in the care of the patient. So just to make a plug, the Medicare's overhead for administering the care for patients is very low, somewhere around 4%, whereas when you get a private insurer involved, it's up to 30% of, so each 30 cents on each dollar is actually spent on the administration of caring for the patients rather than the direct patient care. So in addition to that, what I deal with on a daily basis is what medicine can I give my patients. So one week a particular diabetes medicine may be available with their provider. They switch their formulary and the patient no longer can get that medicine and they don't notify me. So I spend an inordinate amount of time either trying to get prior approval for the medicines or the treatments that I think my patients need, or trying to figure out exactly what they can get based on their formulary. So if you have a single payer system, that becomes much more transparent. And so from the physician standpoint, it cuts down, it allows me to spend more time taking care of my patients, which is what I want to do. I don't want to spend my time trying to negotiate with insurance companies for what I think that patient needs. So I think that going to a single payer system not only benefits our patients and actually will keep us have a healthier population of people because they have access to care, but it actually benefits the physicians who are trying to provide that care. And so the people that won't benefit potentially would be the insurance companies, but with the proposed House bill, there are provisions to help provide the economic support those people need until they can be retrained or have another job. So I'm very supportive of this and hope that we can get it within the time that I'm still working as a physician. So I'd like to hand the mic off to Dr. Charles Codner.
My name is Charles Codner. I'm one of the family medicine faculty here. In terms of my patient care here, I want to echo what Dr. Furman and Dr. Casper said about the complexity of the U.S. healthcare system. And it's not just that physicians have to spend a lot of time in trying to figure out drug formularies or which services are covered or what a patient's insurance plan is. That time translates to an opportunity cost where that we can't spend taking care of other patients, attending to other healthcare needs, or dealing with some of the other issues that patients have to rely on us for. But the medical students here know that in addition to my clinical practice role, I also have a lot of teaching responsibilities, and it's hard to stop being a teacher. And the thing that I wanted to leave you all with today was really just a small teaching point. As we talk about a national health insurance program, there are unavoidable, rather major barriers to enacting legislation about a national health insurance program, as you all have discovered. Part of that, I think, is due to a lot of misunderstanding on the part of the public and our civic leaders about what these terms mean. So in terms of teaching, I wanted to leave you with an idea about 3 different terms that sound like they're related, and politicians get them confused all the time. And in our advocacy work about this, I think it's important to keep them distinct. The first is universal coverage, which just means that everyone in the country has coverage for a certain package of healthcare services. The other is a single payer system, which means exactly what it says. There is one payer. These things are not the same. It is possible to have universal coverage without a single payer system. If you have a single payer system, you almost by definition have universal coverage, but the reverse isn't true. And the last, of course, is socialized medicine, which is usually used pejoratively in the United States, but what it really means is that the government owns the hospitals and employs the physicians as well as other features. These things are not the same. Universal coverage and a single payer system are not the same thing as socialized medicine. And I think in addition to the legislative work that these groups do. I think it's important to have an educational outreach as well. As you talk to congressmen and others, make sure that they're using at least the right terminology in their discussions. And that's really all I wanted to leave you with. So I'm going to give it back to Malika. Take it from here.
Thank you, Dr. Furman, Dr. Casper, and Dr. Connor. So now we'll start with the students. And first off, we have Michael Gesser.
Hi everyone. Thank you all for being here today. My name is Michael. I'm a second-year student here at the medical school. Over the past few months, I've had the opportunity to volunteer at the Shawnee Healthcare Clinic, which is down off Market Street. And I remember one of the first days I was there, the office staff assigned me to contact a list of patients. And it was because some of them were now eligible to receive health insurance. There we go. We're all set. Just to recap, I was told to contact a list of patients because some of them were now eligible to receive health insurance thanks to the Affordable Care Act, and we wanted them to come in and speak with the connector to make sure that they could get set up with their health insurance. However, it soon became apparent that due to a variety of circumstances, they were still unable to obtain coverage. And this is in addition to the many people that, even with the passage of ACA, still do not have coverage. So this is the reality for many people right now across our country. And the truth is that we all have a say in how we respond. With Medicare for All, we can empower all people with the peace of mind that comes with knowing one has health care, which is a foundational component to living a life to its true potential. In moving forward, I want to encourage all students to continue to learn about solutions that would come about with having single-payer system. And I want us to continue also to listen to those who are skeptical of a single-payer system and be solution-oriented in how we respond to them. But ultimately, I hope that we can unequivocally move forward to make sure that we ensure that those who truly benefit from the healthcare system that we have in place are our patients, each and every one. Thank you. And now speaking is Lynn.
Hi, I'm Lynn Summy. I'm a second-year medical student here. I guess I'm going to kind of talk about a little personal story I have and why I believe single-payer healthcare is important. So growing up, I grew up here in Louisville, out in the East End. I kind of was in a lower income family. I was one of 3 kids to a single mom. So we had, enough money to get by, but not enough money to get by, comfortably. So I had healthcare coverage, but it wasn't that great. We made a little bit too much money to qualify for like Medicaid, but not enough to get really good health insurance. And that kind of continued as I went into college. So in college, basically how I got my health care, since I wasn't able to get a primary care doctor, I had to go to the emergency room every time I got sick. And as you can imagine, that kind of gets expensive, every time you have a sore throat, going to the emergency room, paying for the room, the hour, the doctors, the nurses, everyone. So one day, I got sick again, and I kind of looked at my finances and I realized I was not going to be able to pay for another visit to the ER, so I didn't go. It turns out I had strep throat and I didn't treat it with antibiotics, which is, a normal thing that you should be able to do. Just go to your doctor, get a prescription, and go home. And since I wasn't able to treat it, I ended up getting a complication of strep throat, which is rheumatic fever, which I don't know if any of you know about, but it's awful. It's horrible to have. You have joint pain, you can barely move. I was in bed for weeks. And turns out we actually just learned this is something that people usually get in like lesser developed countries, like not in the United States, you don't really see it. But because I didn't have adequate health care, I got it too. And it was something that was so preventable. so easy for me to get, but I just could not afford it. Personally, I don't believe anybody else should have to deal with something like that. You know, I don't think people should have to go to the ER to get health care, you know, when they could easily go to a doctor. I believe that single payer health care would provide health care for everyone, including people like me that, you know, I couldn't really afford it on my own. I think that if we had a system that enabled everyone to get health care, then we would have a lot less sick people on the street. We would have people like me. We wouldn't have people like me that kind of struggles every day with a chronic illness that was super preventable. So I guess that's all I have to say. I mean, I wish everybody could have single payer and you wouldn't have to be sick anymore.
Hi, I'm Sarah Van Gasmick. When I was in college, I went to college in Brooklyn. My family moved out of the country, and so I was left without health insurance. And luckily, I didn't get sick or anything like Lynn, but just for me to go to the doctor to get birth control took weeks of planning to try and get an appointment at Planned Parenthood. It took me an entire day. I had to go in at 7 o'clock in the morning. We had to go through all of my finances. I was put on a sliding scale. It was probably 2 p.m. before I even saw a doctor. So for me, I was really struck at how difficult it was to get health care without health insurance. So when I talk about my parents moving, they moved to Canada. So I have a really great perspective of what life is like kind of on the other side. So my dad got carpal tunnel, and one of the big things that people always talk about with the Canadian system is how long you have to wait to get procedures done. So my dad was diagnosed with carpal tunnel, and it was about 6 months before he was able to get the surgery. And that 6 months was awful for him. It was in the winter in Toronto. His hands hurt all the time. He had to like put them in hot water to get them to kind of open up. But you know what? He did get the surgery. And that's the big difference for me, is that you have people who can't get health coverage who are stuck without getting that surgery. So he did have to wait, but he did get it. So for me, I think that's the big difference, is that I believe that healthcare is a basic human right, and that everyone should be entitled to knowing that their health is going to be taken care of. Thank you.
I'm Justin Watkins. I'm also a second-year medical student, and I just wanted to share with you some of I have a couple of unique perspectives on the issue because of my unusual family situation. I was born to a woman who was born and raised right here in Louisville, and she married a Canadian, and the silly fools moved north instead of south. So I was born and raised in Canada, but I have dual citizenship, and so in my adult life I've gone back and forth between Canada and America and had an adult experience with both healthcare systems. And I've had a lot of experiences with my family and to me, specifically, that have really contrasted the difference between the systems and some of the pros and cons of both systems. One of the things that stands out the most to me is my wife and I had our first 2 children in Canada before I decided to go back to college and become a doctor. And while we were there, those children, everything related to my wife's prenatal care and the delivery of our kids and then their postnatal care was all covered entirely in our taxes. And so we never received a single bill for those things. Medications are not covered in cost in Canada by the healthcare system, so we did have to pay for medications for ourselves. My wife is very violently ill for basically the entire 9 months and is almost unable to eat or drink without medication during her pregnancies. And in Canada, when we were seeing our physician about that care and her needs there, she was prescribed a medication that was considered expensive in Canada, which amounted to just under $200 a month for anti-nausea medicine. And when we moved to America, we moved to Idaho, which is where I got my undergraduate credits to come to medical school. She had our 3rd child, and she was just as sick as the first 2 children. And when she went to the doctor to get care, we were uninsured because Idaho is one of those states that did not pick up the tab between Medicaid and the Affordable Care Act. And so we, as adults, did not qualify for the Medicaid there. and did not have any income because I was a full-time medical student, and she was caring for our children and was pregnant and very ill. And so we went to the doctor, paid our bills, got the same medication because we were comfortable with it. It was very, very safe. And the bill for that medicine was over $1,000 a month, which, when we needed about 7 months worth of that medicine, made it significantly financially more sensible for us to drive 700 miles to Canada to go see our former healthcare physician to get that prescription filled, and then drive those 700 miles back with 2 little kids because it was significantly less expensive. And that's one of those hidden costs. And it's not something that, if you've only ever lived in America, you can really appreciate, I don't think, just how much time and how much burden these kinds of issues are on everyday people. And it's not just the poor, it's the middle class that also struggles with wondering whether they can afford to use the insurance that they have. And that was a real challenge for me coming here. I didn't understand how the system worked. I had to get an education as an adult in the American healthcare system. I didn't know where to take my kids or my wife or me to go see a doctor at first. I didn't understand what it was going to mean to use the emergency room, and I went uninsured personally for 3 years after coming here because of that gap that some states have after the implementation of the Affordable Care Act. And for me, that was kind of unthinkable. I didn't understand why it was that in America, which is the wealthiest, most advanced of all the countries in the world, and had healthcare that's arguably the most advanced and beneficial, that there were so many people who were completely without insurance, and even more people who were paying for that insurance but not able to afford to use it. The contrast between the two was really stark, and I believe that I'd just taken for granted as a Canadian growing up there and living there for a few years as an adult also, that I never received bills for going to the doctor's office. The most complicated thing I had to remember was, did I bring my healthcare card? And if I forgot it, well, then I had to make another appointment. So there are many other things I could share with you about this. The last thing I'm going to say, I know I'm taking a little bit of time, is for my adult life when I lived in Canada, I lived in a very, very rural area, which was underserved medically. So we were 45 minutes from the nearest tertiary hospital when my wife required lithotripsy surgery, which is taking care of kidney stones after our second child. She had to drive 2.5 hours to get to the hospital for that procedure. But those were the problems. Those were the challenges. The challenges did not include, how do we get a doctor? How long are we going to have to wait? How are we going to pay our bills when those things come through? And so having this care for everyone, even though in Canada it's socialized and we're here promoting a one-payer healthcare system, which Dr. Connor, informed us is not quite the same thing. Having that universal level of care for everyone tremendously decreased the burden on everyone in our community for the kind of care that they could receive. And, our concerns were significantly less than underserved populations here that I see and Kentucky see. It's just a matter about logistics of getting to the doctors and seeing people. So I believe healthcare is a universal right. I believe it makes moral and financial sense for America to institute a single-payer healthcare system and bring an affordable level of healthcare to all of its citizens. And that's how I feel. Thank you.
Thank you, Lynn, Michael, Justin, Sarah, for sharing such powerful stories. Would anyone else like to contribute and share their experience? Dr. Lopez, I see your hand.
We're going to switch to Spanglish now. There are two things that I want to mention. First, we must talk about Big Pharma. I have the privilege of working in a free community clinic here in Butchertown, and I had the opportunity to do some ear lavage on a lady who had a very infected eardrums on both sides. So there is a drug ear drops called Cyprodex. And we usually, if we have the medication, we give it to them. If we don't, we help them on the internet finding the one that is the cheapest and where it's sold. This medication, which is excellent and doesn't have a generic, Walmart, a little vial of 10 cc's costs $235. There were other pharmacies who sold it for a little more expensive price. 10 cc's ear drops. I happen to have a brother who is an ENT specialist in Ecuador. I sent him a text and I asked him how much the very same bottle, same pharmacy, same antibiotics and steroids, same presentation, same amount. He sent me even the pictures. The cost is, guess, $10. So here you are. That's one clear evidence that the pharmaceutical industry is reaping us here in this country with the help of a corrupted legislature. The other thing I want to mention is that the very nice distinction that Dr. Kuttner made about socialized medicine. But let's not shy away from the word socialize, okay? It's not a bad word. What we are talking about in single payer is that we are going to have a socialized funding of health care. And the delivery of health care in this country will be through private enterprises. So once again, we need to be sure that we know the distinction between what is socialized medicine, like England, Cuba, versus socialized funding of healthcare, which is very different. I really appreciate the presence of all of you, and thank you very much.
All right, we'll go ahead and wrap up the event. Thank you again, everyone, for coming. Feel free to check out our table. We have some cool swag, and you can sign up the petition to Representative Yarmouth as well. But thank you. Have a good day, and enjoy the weather.